I feel like I'm very lucky to come to work every day and do good for people that need it. There's no better satisfaction really than being able to lift a burden off somebody's shoulders, seeing them relax. A lot of family members are dealing with people with very complicated health needs. That's challenging in itself. They don't need the added pressure of all this stress of things they don't really understand.
Welcome to the Carecast, Stephanie. Lovely to have you on.
Thank you. Thanks for having me.
And hello to all our listeners. Welcome to all of our listeners as well. Stephanie, tell us what you do. Tell us about your company.
I basically, taking it back to when we started Care Necessities, even if we go back beyond that, perhaps, I saw an area for this really when I hit the age of 19. So it started in a very personal way for me. I was in hospital, had a car accident, left me with life-threatening injuries. And on the ward, I came across a lady called Betty, who a lot of our documentation today mentions Betty. That was my sort of initial stage of coming into advocacy, really. Betty had broken her hip, but she also had dementia. I'd never come across anyone with dementia before. As the nursing staff were very stretched, myself and the other patient in the bay ended up very much looking after Betty, trying to distract her, trying to keep her busy, trying to prevent her from wanting to ring family all the time. So that experience really completely changed me. And I went into nursing from there on. I worked my way up. I came increasingly frustrated by the politics of the system that too often stopped us from being able to do what we actually wanted to do. And it pushed me for wanting to do more, really. I wanted to be heard for the people I was looking after. So I retrained in law while I was still nursing at the time. And then I merged the two areas when I worked for a firm of solicitors for a number of years before I then set up Care Necessities. So I brought about the nursing background with the legal knowledge. And everything that we do today really does still come back to Betty. We try to tell her story to our clients because it reflects so many families are facing. The fact that they are vulnerable, overlooked, and perhaps need people to step in because they don't know enough about what they're actually asking in the hospital environment or from a funding perspective. So we draft documents today, like I say, about Betty because of the impact that she actually had on me that never really left me. And so Care Necessities became then an advocacy company, very much trying to get people heard and trying to make sure that particularly those with dementia or the people who can't speak for themselves are able to be listened to and we can make their voice for them. So it's making really sure about the fact that people are truly seen and cared for with dignity. So that's really what Care Necessities came about. We do focus predominantly on NHS continuing healthcare funding, but we also do help with other avenues that it's digressed into. So we will help with hospital discharges. We do visits as well for solicitors, for instance, wellness visits. We do them annually at least, where we'll go and help deputies, attorneys, or even lay attorneys or deputies with making sure that person's getting everything that they need, really. That's really how we came across the Living Care Group and the value it stands beside. It's parrots really what we do, which we like.
Really interesting. How do clients tend to find out about you and then use your services?
So sometimes online, we find that people find our website or through Google, or they will come to us directly through a recommendation from, say, somebody who's probably used our services or solicitors directly. So majority of our work probably comes through solicitors because they are doing later life planning or they're helping people with their position as a professional attorney or a professional deputy. We do also more recently, we've started having more sort of services sent to us through financial advisors as well. Because again, there's a lot of work that sort of works quite well between us all. We don't do financial advice. We don't do legal services. So we're not a threat to any of them. So it's about working together. And for me, it's about that collaborative working with those professionals, but also with care companies or care homes, because we can all then do our best for people if we've got all of those skills.
Really interesting. And typically it's people that really don't understand what is available to them in terms of funding and other services. Is that the usual profile of
Yeah,
person?
yeah. And I think NHS continuing healthcare funding in particular is very complex. And a lot of people don't realise that it's not means tested. So, unlike local authority funding, it doesn't matter how much money you have or whether you own your own home. It's about the eligibility you have because of the nature of your
Yep.
care needs. So, I
Yep.
think because of that, it is very complicated. And a lot of people will be told you're not eligible. But actually, we're finding that people are more likely to screen in than they're being told. My background, when I go back to the nursing sort of profession, initially the CHC assessments were at band 8 level, but they brought them down to ward based level and gave them to nurses to do. And even when I go back then, they didn't give me the training or the guidance with how to do these assessments. So I think if they didn't do that with me, and I'm still finding that professionals don't know as much about it as they should, it's unfortunate that you're relying on people who probably haven't been well educated about this process or how to assess somebody to make such an important decision.
What are the typical things that mean that something falls inside or outside of continuing healthcare funding?
So it's very difficult. So it's essentially if you've got a primary healthcare need, and your needs are health related as opposed to being social in nature, it's more likely that you will meet the eligibility criteria. Now, historically, there used to be guidance on it within the framework to say these are the sort of things that would make you a health need as opposed to having a social care need. They then took that away in a revised version of the national framework. So it's more open to interpretation now because of it, which makes it very difficult. Because again, if you've got professionals who don't know how to apply the criteria, but you're relying on those people to make those decisions, it makes it less certain. So we always say to people, it isn't easy to navigate your way through what is a primary healthcare need over what is a social need. Years ago, what was a social need was very different to what it is today. And you would find that in a nursing home, you would never have anybody sort of say, who was walking around. Now it's very different. It's open to interpretation. So for me, it's about things like, is that person's needs problematic? Are they timely? Are they complicated to manage? Because when it looks at assessment from a CHC perspective, what we're looking at is 4 key things. So it's about intensity, complexity of need, unpredictability, and severity of needs. And so if somebody is difficult to look after or they are timely to look after, so you might, for instance, have somebody who, say, has a swallowing impairment, more at risk of choking, they aspirate regularly, they might have a timely need where it comes to feeding them because they've got a skilled element to it with a spoon, a teaspoon. It's got to be done quite carefully. So it's showing that complexity, but it's also showing how intense and how timely it can be. It isn't obviously just that, it is broader than that. But I think just to give you an example, that probably might help.
Yeah, no, that does indeed. How many people are you able to help on every month or every year, as far as you know?
It's very difficult, really, because everybody's needs are very different. Currently we have capacity to take more cases on. They're very generic. We don't, even though it's a tool that is putting people into boxes, we don't fit into boxes. So it's very much dependent on what the person wants, how much input they want from us, or how little. So we will guide people through the process. So we have some clients who want everything. We have other clients who will say, I'll do bits and you do bits, and then we can support one another. So we might give them guidance on certain things, but then we're not as actively involved. So it's very difficult to say we've got a limit with regards to how many cases we can take. We have in the company, there's 6 advocates, and then we have 3 admin staff, but we have capacity to work for a number of clients. I would say every advocate potentially has, say, 80 to 100 clients that they're working with at one time, because again, it's not consistent working. So we've always got capacity to take more cases on.
And in a year, how many sort of approvals might you get for CQC?
If we're looking at DSTs, so the decision support tool, then potentially I
Yeah,
would
you're not
say, because they're easier to get, it's not as time consuming as an appeal would be. I would say potentially if we were just running if we were just running DSTs, we could probably get through between the six of us, as a guess, I would say probably about maybe 200 to 300 cases. If we're
yeah.
looking at appeals, they do take a little bit longer. Generally, what you're looking at for an appeal at the moment, because the integrated care boards are stretched, you're finding that there will potentially be maybe a backlog of 12 to 18 months. So I would say that's more difficult because it depends how long it's going to take you to get through. But essentially, if you can get them through quite quickly, it would be the same. But it just depends how long it takes to get to that point, if that makes sense. We don't take cases on where we don't think we're going to win. We're very open with clients. And I think that value comes back to when I was nursing. I want to make a difference. I don't want to be taking advantage of people if we don't feel there's value going to be added by us being involved in their care
Uh,
assessments, really.
and and are you often surprised with the responses that you get from, because as you say, you're pretty in a good position to be able to predict whether or not the case is going to be successful. But do you sometimes get surprised at maybe an answer that gets given back?
Yeah, I think you never can prepare for every eventuality. The amount of times you go into a hearing and think that they're going to be very fair, and the nurse assessor will say something that is just ludicrous. I can't say that enough to people, really. We always think as advocates that we are fully prepared for every eventuality, but I do think that you can never foresee what somebody might tell you. I recently had one nurse assessor, for instance, who told me that it was a lady at home and she said to me, we're going to give you nursing care, but because she's in her own home, she won't obviously get that. So I said, we can't look at the basis of you thinking she's going to go to a nursing home because we haven't had that discussion yet. So can we go back to joint funding? Because there are three elements of funding. So the first being nil fund, the second being joint funding, or if someone is in a care home, they'll get funded nursing care. So that's the joint element. Or there is fully funded NHS continuing health care.
And when you say joint, it's joint between which
So
parties?
that's between the local authority and the integrated care board. So it's essentially a joint package. But the nurse assessor, what she actually wanted to tell me was that she was willing to give this lady funded nursing care. So in my opinion, she'd already made her mind up that the lady was no longer staying at home. She was going to go into a nursing home. And I'm like, we need to have a best interest decision if that's going to happen, because this lady doesn't actually have capacity. But why are we not exploring joints? Because if you've got someone in their own home, they can have that joint funded package. We've got a number of clients who are on joint funded packages. And their actual opinion was, because you find this with a lot of integrated care boards now, they are outsourcing to companies that will go and do the decision support tools. So the nurse
Yep.
assessor actually said to me, that's only because my ICB, or when I go back to the ICB and tell them this, they won't give anyone joint funding. And you think they maybe won't, but that's not really for you to not explore simply because there's a political element to it. So that's always really what frustrates me, is they all do it very much locally. It's done very differently all over the country. So although there is a national tool that they're all meant to use, unfortunately, you become acclimatized to them all doing whatever they want, and it becomes a bit of a postcode lottery.
Yep. Yep. No, absolutely. What are the sort of timescales involved in doing an application? And it must obviously vary from ICB to ICB, but the bit of work that you do probably takes a number of weeks, I would imagine.
So if
Have
someone
you-
was to have, say, a checklist,
Yep.
then the checklist would trigger. Ideally, if the integrated care board's complying with their own national framework, they would be looking at getting it done and a decision back to you. So that's having the DST meeting, having panel ratify the DST meeting, and then a decision back to you within a 28-day period. We find that
Yep.
does not happen, but essentially
Yep.
that is what should happen. Appeals, you are looking at a timelier element to it. Like I say, you could potentially be 12 to 18 months for an appeal at the moment, and that's just because of their own pressures. The integrated care boards are stretched. We've recently had one ICB come back to us on a retrospective case, so that's somebody who's recently passed away. We've applied for CHC funding in retrospect, and they've simply sent an email offering no timescale at all, but basically saying to us, we'll do it as soon as we can, but due to staffing, sickness, we can't process it at the moment. So there is no timescale given to us. And I think because it isn't driven by legislative elements, it makes it very difficult then, because it's open to their interpretation of it, it's open to NHS England's supervision of it, and it's open to the Parliamentary Health Service Ombudsman, who sort of essentially monitor it and get involved where they need to. And so it's very difficult, because you are then led by the ICBs on what they're prepared to do and how soon.
Yes, you're at their sort of mercy, really. We did have a client who applied after or during mum's illness, and then she passed away, and they did 6 or 9 months later actually get a positive outcome. So does the fact that someone's passed away alter any of the decision-making process from the ICP's point of view?
I would say not. If anything, it can make it sometimes a little bit more difficult to get funding, because what we're finding is, it's not always the case, but it's very much evidence-based. So for me, if you haven't written something down, it hasn't happened. And so there is no better strength for us than getting involved as soon as possible, really, because we can look at whether everything that should be being written down is being written down. And if it isn't, whether things need to be improved before an application's made. If the records don't substantiate it, when you're applying for a retrospective case, it can be very difficult then to prove. So I think that's the only thing we would always say to people who are applying retrospectively. Look at what the records are saying, because you often find in care homes that they will say things like, or in home care providers, companies, they will be electronic records more often than not. And so there is a generic button that is probably pre-typed. Many of the care homes that I go in use them now. And so it can lead then to very consistent logs of similar entries. And obviously, from an integrated care board's perspective, they will use that to their advantage then, because if it isn't justifying things that are problematic, complex, timely, and it isn't showing that, it's more difficult to prove. So from a retrospective point of view, the only thing that I feel would potentially hinder it would be if it's not written down effectively when you're applying for it. However, when they're looking at a funding perspective, so obviously from what you're asking about the financial side, I don't think that they are difficult with it. There have been a few cases where they have been difficult, but they've been more complex cases where they've probably known about the magnitude of it all when they've taken on the responsibility for funding moving forward. So they tend to be more difficult at that stage. So probably on review, where they're trying to take the funding away, as opposed to the retrospective cases where they can see an end to it because potentially the person may have died. They know that they've only got that period to cover.
Absolutely. What's one of the most challenging cases you've ever dealt with?
So we had a lady, I was trying to think of a good one for today, really, because I know that Living Care Group have a lot of people at home. So we had a really powerful one that we're still involved with now, a lady who obviously I've anonymised a little bit. I'll call her Mrs. H. She has advanced dementia. She is pre-pension age, so she's not even of pension age, and she's got very advanced dementia. She was initially, so prior to our involvement, she was hospitalised. Her husband approached me after they'd already started with the NHS continuing healthcare process. And they basically looked at assessing this lady, found that they didn't find her to be eligible. So obviously at the time where he approached us, it was about whether we could appeal that decision or whether we could do anything, because she was still in hospital at that time. The problem we had is when we looked at this case, she wasn't just in hospital with basic needs. She was needing home carers to go in. She was also needing her husband to go in. So the amount of care that lady required was substantial. So to me, there was something not quite adding up with the fact that she should have been eligible, but they were saying no.
Well,
So we obviously then have got that scenario to deal with. But on top of that, they'd also said, against this husband's wishes, they didn't want her to go home because they said it wasn't safe and they wanted her to go into a care home. So he's got two devastating things to deal with. Firstly, he's going to have to pay substantial costs to get her home if that is an option. And the second element being that she may not be able to go home, even though he'd promised her when her dementia had been fairly minimal, that he was always going to do his very best for her. So this gentleman fought with us to appeal that decision. But rather than...
And by the way, does the decision make it clear what they agree with and what they don't agree with? So they give a clear explanation?
Yeah, so they will give you a narrative. So they will provide you with a rationale on 4 key characteristics. So it's about the nature, the intensity, the complexity, and the unpredictability of someone's needs. So they will come back to you with that. They don't generically give that to you, that they should, because the framework supports that should come over to you with the outcome. But generally you will get the outcome, and then they don't always give you the rest. So it's about asking that question again for that detailing around why she's not eligible. And so this lady in particular that we supported, rather than going down the appeals process, because she was still in hospital and we didn't want to go into a care home, we wanted to look at whether there was an opportunity to get NHS continuing healthcare funding, but to put that in place at home with living care. And so that wasn't a situation where we would simply allow the ICB or the hospital to make those decisions. It was about more, we need to keep this lady in hospital to get her assessed, because that needs to then the better opportunity of potentially getting her back home, which is what she would have wanted and what he wanted. So we stepped in and we asked the hospital, instead of appealing it, to redo the DST, because we weren't happy with it. And we felt that best interest decisions could not be made about this lady going home unless we had the right outcome in front of us. Obviously, that didn't go down particularly well. We weren't welcomed with open arms initially, because obviously we were delaying a discharge from hospital. And for us, it's not always the best option, because obviously this lady is then more susceptible to infections while she's in there. But ultimately, as soon as we could get that done, we did a DST. We overturned the decision. We proved how problematic her needs were. That was by me going into the hospital, working with the staff on what they weren't documenting, because again, it wasn't written down, but also getting the family and the home carers to keep records as well, because then it's more evidence to substantiate what you're saying. We challenged the assumption that she also couldn't return home, because I argued that the better option would be surely one-to-one care at home, because living care was still going to be cheaper than this lady going to a care home with one-to-one care. And it took a little bit of a time to argue with them, but thankfully after a little bit of a battle, they agreed. She then went home. She's now had NHS continuing healthcare funding in place for almost 3 years. So the essential cost would have been, had the family had to pay for it, which they did have means to pay for it, but had they had to pay for it themselves, would have been between £16,000 and £20,000 a month. So we've saved them over £500,000 already of their money had she not received that CHC outcome. But more importantly for me, we've got the lady back to somewhere she's happiest. She's at home with her husband, something that obviously yourselves and a lot of your clients do. It's that value in getting them into an environment that's they're happiest in, or that is more familiar to them.
What an amazing piece of work. You mentioned that the family had means, but who knows if they had £500,000 over 3 years.
Mm.
It's a massive amount of money.
And we still obviously support them now, because obviously initially the review will take place in 3 months, but it will also then be done annually. So we support them now. We prepare for the meetings. So again, I can't stress enough to people who are watching today the importance of best preparing your case before you apply or before you attend any review, to make sure you don't lose it. Because what we do is we get involved. We will contact the families maybe 10 months time and say, your review's coming up. Would you like us to get involved? Let's have a look at the records. Let's see what's being written. Let's see what might not be being written. And let's best prepare our case for whether we're going to lose it or whether we can keep it in place moving forward. Because then you've got another year's worth of funding. And so we do that with Mrs. H or a lot of our other clients.
Do you have a blog or advice on your website regarding informational advice and requirements?
Yes, but we do have. We don't have a blog at the moment. It's something we've thought about doing, to be honest. But we do have a lot of advice there on the website. what we say to people as well is this: if there's any questions at all, just pick up the phone, give us a ring. We don't initially charge for the work that we do. It can be an initial conversation with somebody just to see if they need to do anything before they apply. Just give us a ring, really. We're here to help. Hopefully our website will guide you through sort of the formalities. And like I say, when I get round to it, I am intending to do a blog, so that will hopefully help as well.
100%. What you mentioned that ICBs deal with things in different timescales and in different ways as well. But over time, what changes have there been? And how long have you been doing this, Stephanie?
If I go back to the hospital setting, I would say probably 17 years now. I've been doing NHS continuing healthcare funding, but at Care Necessities, I've been doing it for 9 years now.
And things have changed in that 9 years.
Yeah.
It's become more challenging to
I think,
apply?
yeah, I think they keep revising the framework. It was last revised in 2022. Eligibility is very much tightened up. There's, like I say, although there's a national tool in place, there's huge inconsistencies across the country. Obviously, there's postcode lottery. I think as time moves on, it's going to get harder. They keep trying to bring in the social care reforms that I think they're going to struggle with, if I'm honest. But obviously, I think in time, we'll see more families challenging decisions, more appeals, and more potential for reform. Currently, as well, years ago, there was a Department of Health guide deadline that came in for retrospective cases. So currently, you can only go back to 2012, but I see that happening again soon as well. So if there is a potential retrospective claim at the moment that you can go back to 2012 with, I would be getting people to think about applying now, because otherwise, if that deadline comes in, the last time it came in 2012, some of the clients have only just been getting their settlements for cases. So you're looking at just over 10 years for them to get to that decision, which when you've got someone who's died, you just want to grieve, you just want a bit of closure, and you're left in a situation whereby you're waiting 10 years for an integrated care board to be able to process it because of a backlog. So if there is any retrospective cases out there, I'd urge people to think about maybe whether you apply now.
Yep, definitely. What's the most enjoyable bit of your job?
Well, I think when I went...
Apart from winning, that's the obvious one.
Apart from what, sorry?
Apart from winning an application,
oh, yeah,
that's
yeah, no better feeling in the world. I think for me, it's being able to do what I set out to do in nursing, but could never achieve. Obviously, the politics and the system made it really difficult to be heard for people. I feel like I'm very lucky to come to work every day and do good for people that need it. There's no better satisfaction, really, than being able to lift a burden off somebody's shoulders, seeing them relax. A lot of family members are dealing with people with very complicated health needs. That's challenging in itself. They don't need the added pressure of all this stress of things they don't really understand. And so if we can take a little bit of pressure off with that, that's really what I set up Care Necessities to do. So the fact that we do that every day, I don't think you can put a price on that, really.
What are the key pieces of legislation and policies that people looking for care funding should be aware of?
So the main document that they should use nationally is the National Framework for NHS Continuing Healthcare Funding and Funded Nursing Care, and that was revised in 2022. That is guidance. It's not legislative, but that is guidance that is to be used by the integrated care boards. But there are other laws that we look at as well when we're looking at clients' needs. So the Care Act, very invaluable for people who are caring for their loved ones at home, but also for those who may not meet the eligibility criteria for CHC funding. There's also the Mental Capacity Act. So if someone lacks mental capacity, it's about making sure that best interest decisions are made in accordance with the Capacity Act. We also use the Mental Health Act as well if we've had people who have been sectioned. We've supported a number of those clients in securing funding for them as well. But all of those legislations are ones that we use every day. And if there is any concern for anybody who's watching today, then I would recommend that they go to those legislations. We use those tools to protect people's rights, and they're invaluable, really.
And for an individual or family feeling totally overwhelmed by the application process and how complex it is, what bit of advice would you give to them?
I think I would just say take a little bit of a step back. breathe. And if you don't want to go it alone, just give us a ring. The process is designed to be quite complex, but you do have rights, you do have options. Like I've said already today, it's about best preparing, gathering evidence, asking questions, and you can get expert help if you want it. With the right support, the system then can become much less intimidating. It's unfortunate a lot of the assessments that clients go to become very much a battleground. And I think when you are quite emotionally involved anyway, and you've got a loved one with really difficult needs and you want to be heard, sometimes it can be difficult to execute it if you feel quite intimidated by those who are actually meant to be leading an assessment for you. So one of the things we do is we offer that support to those people. And I find that a lot of them feel as though they've got an ally then, as opposed to it being a battleground. It's unfortunate that it becomes that, but I think if we can make it a little bit less intimidating for people going into that environment, then we always will.
Yeah. Yeah. They could really get sucked into it and take over their life.
Yeah, definitely.
Is there any facility for legal aid type funding for yourselves?
No, there isn't. Unfortunately, there isn't at the moment because they don't like legal support with NHS continuing healthcare funding. In the actual framework, it advises about the fact that legal costs can't be sought purely because they don't recommend that you need them. But obviously, if you asked any of our clients when they've gone into a meeting if they felt like they needed a solicitor or an advocate in that meeting, I think they would all say yes, because they are notoriously difficult, and they shouldn't be, but unfortunately they are.
In your experience, what's some of the main advantages of living care versus other sort of care options?
Like with Mrs. H, really, it's about that familiar environment, particularly with people like who've got dementia. They're very overwhelmed by different environments. So it's just enabling someone to go back if there is an option of that. And that continuity of care, dignity being preserved, person-centred. Obviously, that one-to-one support you get in that environment, it cannot be matched in any care home setting. And if NHS continuing healthcare funding does apply, then it can cover living care just as it would a care home setting as well. But for me, I think it's just, if anyone was asked and they had the ability to tell you, I think they would all say they wanted to go home first.
Yeah, I think so. How does the process for applying for care funding for living care differ from residential care? And what are the specific considerations that families should keep in mind if they are wanting CHC funding for living care?
So if generically speaking, I suppose we've got somebody who's already at home, they've got a decision support tool assessment taking place. It's not accommodation specific. So that is something that I would guide anybody who's going into a meeting with a professional. It's not accommodation specific. So the first question should always be, is this person likely to meet the eligibility criteria for CHC funding? If they do, then is to have a discussion about whether that's an option in their own home or whether we're looking at moving them into a care home setting. The challenge will come with it if that person isn't eligible for CHC and it's subjecting to means tested contributions through the local authority. So if the family haven't got the means to pay for it or the client hasn't got the means to pay for it, then you're going to have more of a battle because the local authority are going to want to negotiate and they're not going to be willing to pay the amounts potentially for living care. But with the right advice, living care can absolutely be secured and funded. And if we can get potentially direct payments through the local authority, if there is an ability for somebody to top up, there is that option. Very similar with CHC, although they'll negotiate the funds down with the living care provider, there is also now a personal health budget, and that's something that came about in 2018. So we can now step away from the fact that prior to all of that, it was illegal for any top-ups to be taken. So a personal health budget, again, would allow for that opportunity. But generically speaking, like with Mrs. H, there is no top-up. Because if you can prove there is that fundamental need and that living care is of a necessity, then there is no reason to have that being taught either. So it's about looking at what scenarios surround that person and applying for the one that's going to best fit.
Really interesting. Stephanie, how would listeners get in touch with you at Care Necessities?
So we do have a website. Obviously, we've got a website. So that's carenecessities.co.uk. But if they just want to have a chat with us, we would say pick the phone up, give us a ring. 01754 800 551, or feel free to email us at info@care-necessities.co.uk. We do, like I've touched on already, we do offer a free initial call, and that is with one of our advocates. So the admin team will allocate you a time that's best to suit to speak to our Julie Reddish. She's our operations director, and she will basically give you any advice on whether there's going to be any added value in us being involved later on at that stage, and there won't be any charge for that. We obviously have some useful resources on our website, but like I say, I would always say to people, pick up the phone or send us an email and we'll guide you through your individual circumstances.
Absolutely. Thank you so much for your time today, Stephanie. And thanks to our listeners for listening and watching. If you found the video helpful, please give it a thumbs up and subscribe to our channel for more valuable tips and insights to help you feel confident navigating your care journey. And don't forget to check out our interview with Sarah O'Sullivan from Renaissance Solicitors about power of attorney. As always, if you have any questions, please leave a comment below. We'd love to hear from you. Thank you very much.
Thank you. Thanks for having me, Luca.